We're good now? Yes, we are. So Dr. Chris Ryerson completed his core clinical training at the University of British Columbia and interstitial lung disease fellowship and master's degree in clinical research at the University of California, San Francisco, before joining UBC facility in 2011. He's a professor of medicine at UBC, director of the St. Paul's Hospital ILD Clinical and Research Program, and head of the Division of Respiratory Medicine at Providence Healthcare. His research focuses on diagnosis, management, and long word of ILD. Sorry about that. Prognostication of ILD. He is also involved in several national and international clinical practice guidelines on the diagnosis and management of fibrotic ILD. Dr. Ryerson's good to go. Welcome, Dr. Ryerson.
Sorry about that, Bob. There was a junk mail problem. Slides got put into junk mail last night. Anyway, thank you for having me back, and it's nice to see everybody here again, and finally get to hear Darcy sing a little bit as well. And I hear that we've got a bunch of people on Zoom listening in as well, so a pretty great attendance yet again. So thank you everyone for coming. Thanks to Fran and to Men and everyone else who organized this for us all. I think it's probably been close to a decade that we've been doing this every year now, and it's great to see that momentum carry forward. So thanks for the kind introduction as well. I'll get started. I'm just looking around. I don't see a TV to see my slides, so I'll have to peek over at my slides as we go. So I was asked to talk a little bit about the patient journey through pulmonary fibrosis and what's next. I thought I'd break this down into four main sections. We'll talk about the patient journey just from a clinician's perspective. I recognize that the experience is often very different for patients and for family, but I'll tell you my 2 cents about the patient journey. We'll talk about management and a kind of an overview of management and how we think about pharmacotherapy as well as non-pharmacologic treatments. And then I was asked to talk about acute exacerbation, which we'll spend a tiny bit of time on. And then we'll talk a little bit about challenges and treatment options as well. So the patient journey. So the question is what's next? So when patients come to us, really there are two main paths that patients can start off with. They either have symptoms or they have incidental identification of pulmonary fibrosis. And that might be because they had a rotator cuff injury and they had an X-ray or a CT scan of that injury, and they found something in the lungs, and they end up going to their GP, have a bunch of different tests that are done. Usually that includes pulmonary function tests and a CT scan. They may get seen by what we would call a general respirologist, or a respirologist who's not really focused on interstitial lung disease or pulmonary fibrosis, which would be a synonym. And then they end up coming to an ILD respirologist, somebody like me. We work in a team. So in that situation, we would review the case details with other respirologists who are like-minded, with radiologists who would look at the CT scan, maybe a pathologist if there was a biopsy. And then we would come to a consensus diagnosis and talk to the patient about the subtype of pulmonary fibrosis that they have. And then there would be a whole bunch of questions that patients would ask that we'd hopefully answer up front, and further things that patients would ask. And the common questions really are, what's my diagnosis? What's my prognosis? What are my treatment options? And then what else can I do? And the caution here is that you have to be really careful about where you get your information from. And there's a lot of different places that you could look. I'll talk a little bit about the internet, because that's a common place for people to look. And I Googled this a few years ago, and actually it is the International Powerlifting Federation, I think, that you actually find when you search for IPF. Or when you ask Siri about IPF. I think the internet is a little bit smarter than that. So you have to be careful about what you find on the internet. This is a famous quote from Abraham Lincoln, who was not very satisfied with the internet back in his day. So we did an interesting study. I don't think I've presented this study here, or maybe not in a while. So this was a study that a few of us did from 7 or 8 years ago now. That we wanted to see what patients were looking at online. So we literally purged our search history. We looked at the top 200 hits on Google, Yahoo, and Bing, so 3 common search engines. And we wanted to see what kind of information were patients reading out there. And this was, we went through what the information is that's helpful, that's accurate and informative. But what was really interesting about this paper was the harmful and inaccurate information that is out there online. So this is a list of the treatment recommendations made in various websites that actually harm patients with pulmonary fibrosis, but are being recommended by various websites for the treatment of pulmonary fibrosis. So to highlight those a little bit, the first 2 on the left, if you have idiopathic pulmonary fibrosis, this doesn't apply to everybody, but if you had idiopathic pulmonary fibrosis, prednisone and azathioprine in the long-term use increase mortality. So these are not good medications to be on if you have idiopathic pulmonary fibrosis. Many of you do not have idiopathic pulmonary fibrosis. Many of you will be on these kinds of treatments. That's a different situation. This just goes to illustrate, though, that if you have IPF, this is often what's being found online, is that you'd be recommended to take these inappropriate treatments. There are other treatments that have no benefit and might actually exacerbate pulmonary fibrosis. There's some clear bias out there where there are these sites that are selling these medications, so-called drugs, that they're actually just trying to make a buck off of people. And then there are some other ones that are very, very experimental. Literally 9 patients who have been studied in this one instance, and this treatment was being recommended, despite about a quarter of people dying shortly after getting that treatment. So that's a snapshot of what's out there online. The more concerning part is that if you look at the different types of websites that are out there, it's actually what we labeled as scientific resources. So these are coming from university organizations, and then foundation and advocacy organizations like, not specifically the Canadian Pulmonary Fibrosis Foundation, but things like the CPFF, were the ones that were most likely actually to recommend these inaccurate treatments. And the reason for this is interesting. So if you look at this, it was frequent that these websites weren't being updated. Even if they said that they were being updated, they weren't being updated. And so they weren't keeping up with the evolution of evidence that took us from these old historic approaches to treatment to new, more evidence-based approaches to treatment. And if you fail to update your website, then you're left with outdated and often inaccurate or even harmful information. That's what we were seeing online. So the bottom line is that you have to be very careful about where you're looking for information. Interestingly, the best performing website was Wikipedia. Not sure if anybody here has looked at Wikipedia for pulmonary fibrosis, but it's quite comprehensive. The crowdsourcing approach actually keeps information relatively current. Problem with it is that it's written at a pretty intense level, so the readability is fairly poor, but it is the most comprehensive and generally the most accurate source of information. And that applies for pulmonary fibrosis, but it applies to other things as well. Whatever topic you're interested in, Wikipedia is actually relatively accurate. The best source, though, is going to be your respiratory physician, your ILD doctor. So ask questions when you see that person. So first, what's your diagnosis? I'm not going to spend a lot of time talking about this. There are a lot of different terms that we've thrown around. So the way I think of it is that interstitial lung disease is a really big umbrella term. Pulmonary fibrosis is also a almost as big umbrella term. So we have what we call an interstitial lung disease clinic, and we are ILD specialists. About 95% of what we do relates to pulmonary fibrosis. The other 5 or 10% is non-fibrotic interstitial lung disease. Fibrosis means scarring. If you have scarring, generally that scarring gets worse over time. If you don't have scarring, then your response to treatment is often quite good. So that's why we're often focusing on pulmonary fibrosis, and I'll use those two terms mostly synonymously today. Within that pulmonary fibrosis category, there are a number of different specific diagnoses, and that would include things like idiopathic pulmonary fibrosis, hypersensitivity pneumonitis, connective tissue disease, associated ILD or autoimmune-related diseases, and then there's a whole bunch of other ones as well that are less common. So again, the ILD doctor will look at your CT scan, talk to you about all the symptoms that you might have, do some blood tests, maybe do a biopsy, put our heads together, and then you'll be given one of those labels. There is a large group of patients as well that have an unclassifiable interstitial lung disease where they kind of fall between the cracks a little bit. They probably have one of these things that's listed here, but we're not able to confidently identify that. So I'm sure some of you have been told that you have an unclassifiable ILD as well as one of these specific diagnoses. This gives you an idea about the breakdown of these. So we see in the orange here, a little bit more connective tissue disease than anything else. IPF is probably number 2, unclassifiable number 3, and then hypersensitivity number 4, and then a variety of others that make up the remainder. So it gives you a bit of an idea as to the breakdown. We often focus a tiny bit more than is appropriate, probably on IPF, at least more than appropriate based on some people's perspectives, largely because it's been the most studied interstitial lung disease, and it's also the most progressive interstitial lung disease. So often treatments are studied in IPF first for those reasons, and then they might get extrapolated to other ILD subtypes over time. So the next question that patients will often ask is, what's my prognosis? And there are 4 kind of main things that we look at to estimate prognosis. And this is a very, very imprecise science. So we'll look at symptoms, shortness of breath, mostly. Sometimes cough can be a little bit informative, but it's really shortness of breath and functional limitation. So your ability to exercise. Related to that is your need for oxygen. And then 2 tests that we do are pulmonary function tests and CT scans. For patients with ILD, we're usually doing PFTs or pulmonary function tests every 6 months or so, but we might do them more often if there's some progression and we're uncertain about things, or less often if we're pretty confident that things are stable. CT scans, just because they're a little bit trickier, there's a tiny bit of radiation, which probably doesn't really matter in this situation, but we'll typically do a CT scan every year or 2. So that's how we measure prognosis at baseline. But really what's most informative is how patients have done in the recent past. So we can measure all of these things, but what's really helpful is to follow their trajectory over time. And this is just showing a few different ways that progression can happen. There should be another line up here that's relatively stable. But patients can go get a little bit worse, a little bit more slowly, really quick, or they can have like a very, very rapid decline with things like acute exacerbations, which we'll come back to in a minute. So just to illustrate that on the CT scan, this is a patient. I just copied the CT scan forward. This isn't real, but patient could have long-term stability where you don't really see anything that's changing over several years on the CT scan. There are some patients as well that will have what we call progressive pulmonary fibrosis, where if you look at the CT scan, the amount of white in these regions of scar tissue get more and more white over time. And that's somebody that we would be more concerned about, and we'd be talking about active interventions to treat that. And then there's some patients that have acute exacerbations. They may be progressing or not at baseline, but then all of a sudden they have a whole bunch more of this white inflammatory kind of looking stuff on their CT scan. And that's a concerning development for patients. It's fairly rare, but does happen on occasion. So the way that works, this is not really meant to be understood in too much detail, but this is a snapshot of what a normal lung would look like, a very delicate lace-like appearance to the alveoli, which is where the gas exchange happens. With things going into the bloodstream. So there's kind of air up here and then blood passing along down here. If you have IPF, things get a lot thicker and oxygen doesn't diffuse into the blood quite as easily. And over many years, you get a whole bunch of this fibrosis or scar tissue that forms, and that impairs gas exchange and leads to shortness of breath. With patients who have acute exacerbation, you have a trigger, and this could be an infection or severe aspiration or something else that leads to very, very rapid inflammation in these regions that then leads to a whole bunch of the scar tissue formation on a very acute basis. And this can happen over the span of a few weeks rather than the few years that this takes. This is fortunately a relatively rare event. This is a summary of some different articles that we published a few years ago looking at how frequent these types of events happen. And it's probably between 2 and 5% of patients per year will have an acute exacerbation. Unfortunately, they're not able to be predicted very easily. We see them often with infections. COVID was a common culprit of that as well. And unfortunately, other than it happening a little bit more frequently in patients who have more advanced fibrosis, there isn't really a great way of predicting these events. They're relatively sporadic. And I should add as well in the bottom here, these are fairly uncommon in IPF. They're actually much less common in other subtypes of pulmonary fibrosis like autoimmune disease and hypersensitivity pneumonitis. So the next question is, what are my treatment options? So there are several things that we think about before we start thinking about drugs. We often kind of jump to medication, but there are several things that everybody should be thinking about all the time. And collectively, and maybe even individually, these all have more impact on how patients are feeling and functioning rather than the medications do. I think with relatively rare exceptions. So if you're a smoker, quit smoking. It's never too late to quit smoking. If you need oxygen, you do not get addicted to oxygen. You don't get dependent on oxygen. If you need oxygen, going on oxygen can help preserve your heart function and allow you to do more. Pulmonary rehabilitation is a fancy word basically for exercise for patients who have lung issues. Usually we're talking about walking. It might be a treadmill, it might be a bicycle. It's really whatever you're able to do. Generally speaking, people are a little bit afraid to exercise, and so pushing it a little bit makes sense. The usual rules that I give people are that I don't want you to have chest pain, don't want you to be lightheaded, and I don't want you to be exhausted that you can't get out of the bed for the rest of the day. If you're not reaching those kinds of thresholds, generally speaking, you can do more exercise. In people who have a pulse oximeter, and I imagine many of you guys have a pulse oximeter, if you're above 88% or so, you're sailing, you can keep exercising and go as intense as you can, as long as, again, you're not having that chest pain or lightheadedness. The typical advice that I give to people, which is maybe not evidence-based, but probably is a practical approach, is that if you're between 82 and 88%, you can be in that zone for a minute or two, maybe as you're finishing off your exercise, but we don't really want you to be hanging out down there because that does put a strain on the heart. And then I typically say that below 82 is the danger zone. We don't really want you going below 82 ever. So that's when you do have to take a little bit of the intensity down. Vaccination is obviously important. Some people have had reactions to COVID vaccine, and we do have kind of case-by-case discussions of whether COVID vaccination is appropriate in that situation. But otherwise, vaccination is kind of an unambiguous, yes, you should do it. Treatment of comorbidities, we'll come back to this in a sec. So that could be acid reflux. That's what GERD stands for, basically, is reflux. Treatment of your mental health is important as well, whether that's anxiety or depression or whatever else. That has a huge impact and also has a carryover impact on all these other bullet points that I've listed here. And then lung transplantation is sort of the ultimate treatment of pulmonary fibrosis. It's not the right thing for everybody, but if it is the right thing for you, it can make a huge difference. And then medication, I'll talk a little bit more about. So before I do that, this is sort of how we're starting to think about treatment of patients with pulmonary fibrosis. We're really trying to take a bit more of a comprehensive approach to managing the whole patient. And some of that relates to managing what's going on in the lungs. Some of it is related to comorbidities that are commonly associated with pulmonary fibrosis, whether that's your heart or acid reflux or something else. And then there's some treatments of things that are going on elsewhere in the body as well, whether that's leg exercises or treatment of whatever else. Really, we're trying to look at the whole patient and not just focus on the lungs as we often tend to do. I won't go through this in too much detail, but just to show if anybody is really interested in this, you can try to look up this article down here. And it provides a kind of a comprehensive approach to management of patients with pulmonary fibrosis. And you can actually look through this long list of various things and just say, hey, do I have this? And if I do, I should be on this type of treatment that's listed over on this right side. All right, so then we come to medications. So medications is a complicated and an evolving area of pulmonary fibrosis. So the way that we've historically approached this, and probably currently most people approach it in this way, is that we think about the etiology, or we think about the underlying diagnosis. And there's a dichotomy here where you either have IPF or you have something else. If you have IPF, we give you an antifibrotic medication. There are two that are on the market. There's nintedanib and pirfenidone. There are additional ones that are in clinical trials that we hope will be beneficial and maybe come with fewer side effects or better effectiveness. But at the moment, there are just those two antifibrotic medications. If you have a non-IPF subtype of interstitial lung disease, so again, these would be connective tissue diseases or hypersensitivity pneumonitis or potentially others, then we typically are using these immunosuppressive medications. These slow down progression of these conditions. They're actually harmful in IPF, and that's why we have to make that pretty clear distinction of whether you have an IPF diagnosis or something else, because the treatments of this something else, these medications, actually are harmful in IPF. If you have progression despite these medications, that's when we add an antifibrotic medication. So again, nintedanib or pirfenidone. Nintedanib would be usually the first line medication in that situation. So it's a little bit different, IPF versus non-IPF. We're moving more and more towards what I would call a morphology-based approach to treatment, where we take a look at the CT scan, how the pictures look on the computer. We might incorporate other details from a biopsy or a bronchoscopy, which is the camera down into the lungs. And we try to get a sense as to what the underlying biology is. And we think we're doing a little bit of a better job by looking at the CT scan and some of those nuances than by just putting people into a kind of a black and white IPF bucket or a non-IPF bucket. So we're probably doing this more and more. And so the treatment decisions are getting more and more nuanced as a result. And you actually have to be a pretty good chest radiologist to effectively manage interstitial lung disease at this time. So the way I think about this kind of morphology approach to treatment is that there are two stages of treatment. There's the short-term treatment of patients who have rapidly progressive and then hopefully rapidly reversible interstitial lung disease. And then there's the long-term treatment that's intended to slow down the future progression of fibrosis. So the short-term treatment are the people who have these types of features listed in yellow. So these are patients who are coming into hospital. They're quite sick. Things have progressed over the span of a week or two, or maybe a month or two. They've got a CT scan that looks really inflammatory. They've got inflammation on biopsies and bronchoscopies. And those types of patients, we can give prednisone, and often they feel dramatically better even within a few days. Maybe not back to normal, and there may be future progression, but we can make them a whole lot better quite quickly with prednisone. And then there's the long-term treatment. And we have sort of three main categories of approach to management in that situation. So I'll zoom this in a tiny bit. So on the left, there's a whole bunch of features that I've listed here that suggests to us, for one reason or another, that the patient has either very mild disease that's unlikely to progress to the point where we would want to put them on treatment and have them potentially have side effects. So they might have either very mild disease, or they have other significant health issues going on that make them unlikely to benefit from a treatment of their lung issues. So to take an extreme view, if you've got terminal cancer and you're going to die in a month or two from that, why would we wouldn't be treating your interstitial lung disease that's going to progress over the span of years? So that's the extreme, but there's a lot of a gray zone in between there as well. So that's the very mild or the very, very risky kind of situation where we wouldn't treat at all. In the middle, we have the immunosuppressive kind of approach. So these are patients who have some grumbling inflammation, and we would use an immune suppressing medication to calm down that inflammation and slow progression using that tool. On the right side, we have the progressive scarring situation where we would use that antifibrotic or that anti-scarring medication, and things like nintedanib or pirfenidone. And then sometimes we have patients who would be on both of these anti-inflammatory immunosuppressive type of treatments and the antifibrotic type of treatment. So that's how we're generally approaching things nowadays. And I think it's a better approach than what we've done in the past. I will say, though, that this is still not an ideal approach. There's a lot of research that's being done in this area, and we're hoping to move towards what we would call more of a molecular-based or a precision medicine-based approach, where we would be able to do something like a blood test that says, hey, you've got this blood marker. This is the treatment for people with that blood marker. Right now, we're just making guesses on biology based on what we see on the CT scan. So we're not quite at that point of precision medicine yet for patients with interstitial lung disease. So the next question is, what else can I do? So just a few things that I would highlight are to look after yourself, but also accept help when it's needed. And that's a tough thing, especially as a middle-aged guy. I can see I'm not a very good person at accepting help. And I'm sure some of you guys are kind of the same. Educate yourself and others. So learn about the disease, learn about it so that you can share whatever details you think are appropriate with your family members. And then learn how to advocate for yourself and for others who are in this room. And there's a lot of good resources, whether that's the BC Lung Foundation or the CPFF. There are ways that you can start to advocate for yourself. And some people in this room are fantastic at doing that already. And I'm sure would love to share that experience with the rest of you as well. And then help us learn more as well. And I think being here and hearing your stories helps us. But also participating in research, whether that's registries where we collect data so that we learn more about the disease, whether that's participating in clinical trials. I think that's often a nice thing for the community at large if you're able to contribute in that way as well. So to summarize a few take-home points. So we talked about the patient journey. It is a journey. It's a challenging one. Try to ask the questions of your ILD specialist and consider other sources of information as well. We talked about the approach to management. There are a number of non-pharmacological things that everybody should be considering. And then we talked about the medication side of things as well. Acute exacerbation, we talked very briefly. It's an uncommon, but it's a serious event when it happens. It's characterized by superimposed inflammation on the background of fibrosis. With that underlying biology, we often do end up using steroids as well as antibiotics and oxygen and other treatments in the short term. And then we talked about some challenges with the current treatment options. We didn't talk too much about this, but the treatment options are imperfect. They don't stop progression. They don't reverse disease that's already there, and they do come with side effects. So we're always on the lookout for better treatments, and it's a bit of a slow process, but we are getting better and better at doing this. And then lung transplant obviously is a major intervention, but is not right for everyone. And then the last thing, what else can I do? There's lots, and you guys by being here and sharing your stories, talking to other people is a huge advantage for us as well as the community. So with that, I'll say thank you again for everybody coming. Thank you again.